All right, guys, welcome back. It's me again. I'm going to be talking about growth plate injuries in young kids for the next probably 10 or so minutes. So we're kind of moving into the injury section of the symposium here. So we're going to look at a little bit of growth plate anatomy and then talk about how we classify these things and talk about what's the difference between a physis, a growth plate, and an apophysis. And then we're going to look at a few of the specific injuries and talk about some of the more common ones and benign ones to the more challenging ones, and then discuss a little bit about remodeling potential and growth potential in kids. So to understand these injuries, you got to kind of know what a growth plate is. So to review for everyone, the shaft of the bone is called the diaphysis. The ends of the bone are called the epiphysis. Kind of where the two meet is the metaphysis. And then you have the growth plates on either end. And then you have these other little things called apophyses. And the average age that these close in girls, it's about 12 to 14, which is about 2 years preceding menarche. And for boys, it's a little bit later, 14 to 16. So when you hear about, oh, I grew until my freshman year of college till I was 21, it's like, I caught a fish this big. It doesn't really happen. And why does this kind of stuff matter about when kids are going through these big growth spurts? Is because that's when most of these growth plate injuries happen, in the kind of preteen years. And it's because kids are growing really, really fast. And if we go back to some of our basic science and biology, the growth plate consists of all these cells. And when kids grow really fast, there's this portion where it looks like a bunch of bubbles that get big. It's called the hypertrophic zone. And that is where the fracture occurs. And so to understand how we treat some of these injuries, we got to know a little bit about how much things grow. So in the upper extremity, the growth really occurs proximal and distal. So really most of the growth comes from the shoulder and the wrist, whereas much less comes from around the elbow at the distal humerus and proximal radius ulna. Where it's the opposite in the lower extremities. Most of the growth occurs around the knee, so about 70% of the femur, about 60% of the tibia, whereas the remainder comes from the other end. And we kind of also have to understand what's a physis and then what's an apophysis. So physis is the growth plate. It contributes to the longitudinal growth of the bone as well as the girth of the bone. Whereas an apophysis is not really it's a bit of a misnomer. It's really not a physis per se. It's a separate ossification center where it gets its name from, but it's basically where a tendon inserts into a bone. For example, where the patella tendon goes into the tibial tubercle. And it helps to contribute to the shape of the bone. And it can be subject to certain stresses during periods of rapid growth, which we'll hear about in a couple talks from now. When we classify these injuries, we all use the Salter-Harris classification, and there's kind of a little bit of a mnemonic to go through with this. So type 1, the fracture goes straight across or shears the growth plate. Type 2, it goes through the growth plate and then propagates through the metaphysis or above the growth plate. Type 3 is where it goes through the growth plate and then propagates down into the joint, into the epiphysis. Type 4, where it goes through the metaphysis, crosses the growth plate and into the joint or into the epiphysis. And then type 5 is sort of the elusive type 5. It's more of a crush injury from an axial load. And some basic principles about growth plate fractures that we want you to know are that, first of all, these things heal really, really fast, about 3 to 4 weeks usually. And you have a very small window of opportunity to do something about it if you need to do something about it. Less than 1 week, you have less than 1 week to be able to manipulate these things. Salter-Harris 3 and 4, where they go into the epiphysis and into a joint, usually requires surgery, or oftentimes requires surgery. And then we need to kind of put a bunch of these pieces of the puzzle together to predict problems. So we have to kind of get a sense of what growth potential is left in a child, as well as remodeling potential. And essentially, the more displaced the fracture is, so the worse the fracture is, the higher the risk is for a long-term problem. So we're going to go over a few the specific injuries here over the next few minutes as examples. So in the proximal humerus, you can see in this picture here, it's almost always a Saltires 1 or 2 injury. This happens in kind of the preteen boy, and it's usually a fall directly onto the shoulder. And we talk about this, we oftentimes say it's that the scoop of ice cream has kind of fallen off the cone. The cool thing about these fractures is that you really very rarely have to do much about it. Because if you remember from one of the first slides, about 80% of the growth of that bone comes from that proximal humeral physis, which means there's a ton of remodeling potential. So you see this initial x-ray and you kind of are like, oh my gosh, this looks awful. But you really don't have to do much. You can put like a little cast on if you want. And about 3 months later, it's healed, and look how a tremendous amount of remodeling almost looks normal without us doing much of anything. So for most of these proximal humerus fractures, we are able to treat it conservatively without surgery. If the kid is under 10, pretty much you can leave it in whatever zip code you want it to, and it's going to find its way home. If kids are about 10 to 12, we accept 60 to 70 degrees of angulation. We talked before, orthopedics, we love all these angles. And, you know, so basically, if you saw this fracture in like a 10-year-old or 11-year-old, you wouldn't do much of anything. As kids get older and there's less time for them to kind of grow this out correctly, that's when we start to think about surgery. And with surgery, we basically line it up and put a few wires back in to hold it together, and kids do great with this. We talked about these things healing fast. They do. They heal really fast. So even if we do put pins and everything like that, the pins come out at 4 weeks or so. They start moving the shoulder around, and they're really back to doing all the things that they want to do by about 3 months or so, 3 or 4 months. Another common one in the upper extremity is the distal radius fracture. This is usually either a Saltires 1 or 2, so it shears through the growth plate. It happens in girls a little bit younger than boys because of the time frame that they mature, and it's almost always that the kids fall onto their outstretched hand. Oftentimes they come in with significant swelling and deformity, like you see in this picture here. So the tip of the metaphysis here, and this is the tip of the epiphysis here. So this really, it's like the hat just needs to be put back on the head there. So we push it back. Usually it doesn't take too much. Usually it just takes a little bit of a push, and it goes right back into place. So most of the time, that's all we need to do. Either do nothing, because it will remodel tremendously, or we just pop it back into place and put them in a cast. The thing about that is you need to get to it quickly. We said you have to get to it within a week, or else you can induce more growth plate damage when you try to put it back. Or, and you only get one chance to do it, because if you try to push it back into place and you have to use a lot of force or try multiple times, that's when you can actually induce another growth plate injury. And then we see them pretty closely in the very beginning, because even if you push it back into the right place and it looks great, they oftentimes have a tendency to slip back where they came from. This is an example of one that actually doesn't look too bad. Somebody put it back into place and it looked pretty good, but the kid was developing a compartment syndrome, acute carpal tunnel syndrome, so they had to take the cast off. And then the fracture completely fell apart, and so we had to go back and do a little pinning, at which point then they did great after that. So these, again, they heal fast, about 4 weeks in a cast. Oftentimes we'll put a brace on for another couple weeks after that, and it's a very, very forgiving physis. Usually I don't see these in the very long term. I don't check the growth plate, 6 months or a year later, unless the reduction was done by somebody that, or somewhere where I don't know how much they struggled with it, or if it was a really bad injury to begin with, very displaced. And the worst thing that kind of happens is that the distal radius stops growing, and the ulna keeps growing, and you can get some ulnar-sided wrist pain with that. And all we need to do is, if we catch it early, we can stop the growth of the ulna. If we catch it a little bit later, we shorten the ulna to kind of equalize that relationship. And then this is probably my favorite one to do in the office. This is a small finger fracture. It's a Salter-Harris 2 fracture of the proximal phalanx here. And they call it an extra octave fracture, because if you're playing piano, you can now reach that extra octave. And usually it happens in sports because the finger gets caught on a jersey and gets kind of like pulled out to the side. So this is something that you guys can do in the office as well when you see it kind of pointing in space, is you basically just put a pen way down, jam it way down into the web space there, and then you just push the finger over to the side, and it usually straightens up really nicely. And then a splint for a few weeks, and then they're kind of moving on with life after that. Going to the lower extremity, we're just going to talk about a couple different fractures in the interest of time. And so we talk about growth plate fractures around the knee being either the distal femur or the proximal tibia. And these most commonly are with football. They can also be, we've seen these with trampolines, not infrequently. And they come in unable to bear weight. Oftentimes the knee's held in flexion, they can't move it out. And the thing you got to be really concerned about is vascular injury, because of the location of the popliteal artery in relationship to these growth plates. It's basically plastered right up against the back of the bone there. And these have a high incidence of compartment syndrome as well. So with a knee physeal fracture, this is an example of one here. And something about the growth plate here just doesn't look right. And this child, I'm sure, had a ton of pain and tremendous amount of swelling. And so that should tip you off that there's something going on here. And you may get some other views that make it more clear that there's a distal femoral physeal fracture. And even if it doesn't look too bad, I closely observe all these. I usually will admit them overnight because this happens out at a football field or something like that. They're transported, and then sometimes in that transport, it sort of auto-reduces a little bit. So you never know if it really looked like this image on the left of the screen and something happened to make it look a little bit better than it really is. And for the treatment of these, most of the time these need surgery, really because putting them into a cast acutely can be dangerous because of the risk of compartment syndrome. So most of the time we need to put some type of metal augmentation in there so that we don't have to put like a tight cast on that's going to hold it in place. And generally speaking, with these types of fractures, whether it's in the proximal humerus, if we need to do surgery for it, or the wrist, we usually use kind of a percutaneous or a minimally invasive approach with wires. We can put some wires across a growth plate without any long-term sequela to the growth plate. We're not messing anything up. And we talk about the risk of growth arrest later or growth problems later. And the bottom line here is that around the knee, there is a very high rate of growth disturbance, whether it's distal femur or proximal tibia. It's a very rapidly growing growth plate or physis. So there's actually a very high likelihood that you're going to need to do something later on. And by doing something, it's a little outside the scope of this, but it usually means some type of deformity correction surgery. And then lastly, we'll mention the tibial tubercle fracture because it's one of the more common ones we see. This is actually an apophyseal fracture. The quadriceps muscle is really strong, and so the contraction of that very forcefully on the tibial tubercle will actually kind of like rip it off or pop it off. And this is almost all, it seems like every time I see this, the kid is playing basketball. And the thing to worry about or to keep in mind about this is there are fairly high rate of compartment syndrome because the anterior tibial artery lies right over the top of the spike of the tibial tubercle. So when it lifts up, it can tear that artery and cause bleeding. So the treatment of this, because of that, in my hands, it's fairly urgent surgery. They're admitted to the hospital, and it's usually done within several hours. And then I always release the compartment tube because I don't like to get calls in the middle of the night with concerns from residents or anyone they think a compartment syndrome is happening. So I head it off at the pass. And usually I don't trust kids too much, so I usually will put them in a cast unless I really trust them, and then they'll get a brace. And they're usually back playing sports 3-4 months after the injury, believe it or not. So in summary, understanding certain principles about physeal injuries will help to guide treatment in terms of how much growth is remaining, what growth plate it is, and how bad the fracture was. We're a little bit more surgically based treating the lower extremity fractures versus the upper extremity. The lower extremity fractures have a higher risk of needing more stuff down the line because they have more problems. And then surgically, it's kind of less is more. We usually just do minimal metal and then put some type of brace or cast on to augment that. And then basically we plan from day one what's going to be our long-term plan. We try to predict problems and counsel the families that they may need more surgery down the line if the growth plate is adversely affected in the long term. Thanks.